Mr. Westerman from Arkansas, recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Hadley, for being here today. Have we been given a copy of your work and the model you use to evaluate CMMI? The answer to my questions might be self-evident, but since we don't have that, hopefully you'll be able to provide some answers and explain. And when I hear about all of the great things that are happening as a result of CMMI and your rave reviews of cost savings and better quality, it makes me wonder if my congressional district might exist in some alternative universe, because that's just the opposite of what's happening back at home. I could give you lots of examples. I've got a border county with Louisiana, a rural area, has one hospital there because of a Medicare program. The closest ambulance service is in Louisiana, but they don't want to come across the state line to transport patients, so the one ambulance service in that county eats the cost when they go outside of a 35-mile radius to transport somebody to the hospital. So my question is, does your analysis make any provisions for rural versus urban areas?
So we would look at specific demonstrations to the extent that that's been an area of focus of the center, then we would expect there to be more demonstrations in that area. To the extent that the center hasn't pursued very many demonstrations that are focused on rural areas, then that would be an opportunity for future demonstrations.
So you haven't had many demonstrations, but you're projecting a huge cost savings from the result of CMMI. So that leads me to some specific questions. That these are practical things that I hear when I'm back home. Does your analysis consider any cost to Medicare on hospitalization when durable medical equipment money is saved by not allowing home delivery of any diabetic test strips?
So when we considered the demonstration that involved durable medical equipment, we looked at all of the information that was available to us, all of the evidence about the overall effects of spending, but I don't know more about the specifics of that demonstration.
I mean, this is a real-life problem where rural patients can't get diabetic test strips delivered because of some cost-saving program. Does your analysis consider overall cost to Medicare on hospitalization versus the savings on durable medical equipment when a competitive bid walker is drop-shipped to a rural patient and it has to be assembled by the patient?
Again, we only looked at the overall effect, and I don't have the specifics for that specific demonstration.
So you don't have any real-world experiences like that, yet you're able to project that this program's saving money for the federal government, plus providing better quality services?
So our estimates are based on the historical performance of demonstrations before the center was established and the expectation that the center will cancel the demonstrations that do not produce savings or that harm quality.
Does your analysis consider cost to Medicare hospitalization when DME saves money by not allowing companies to clean and service oxygen concentrators for home health patients?
So our overall estimates of Medicare would consider that kind of evidence, and and we'd be happy to look at it if.
You probably haven't looked at that so far.
I don't know. I assume our analysts have, and I will check with them.
Yeah, we don't know what you've looked at because we don't have a copy of the model. Does your analysis consider the poor health outcomes and increased hospitalization costs when RAC audits to meet a quota prevent payment on a pair of orthopedic shoes for a diabetic patient?
The model looks at a more general approach because we don't know enough about specific demonstrations to be able to make specific estimates of a generic demonstration going forward. So I'm not sure which demonstration project that CMMI is concluding that connects to.
So do you see the disconnect when I go home and talk to my constituents and I hear these are real examples? Every one of these are things that I've had brought to my attention, that I've had meetings on with people in my district, and then to come here and see a report that says that because of CMMI and these demonstration projects and some of these things that have been implemented, we're providing lower cost health care and we're providing better health care. And that's certainly not what's happening in my district.
I understand your concern, Congressman, and I appreciate that the Congress is charged with a much broader set of responsibilities than CPO. Our role is to provide our best estimate of the likely savings or costs of legislation.
And my point is I don't think you're taking into account all of the situations that exist out there in the real world when you're making this analysis. I yield back.
Gentleman's time has expired.